everyone. Welcome to November ASCP Virtual Pathology Grand Round. Just a few housekeeping items before we start. Please mute yourself during the presentation. For questions, you can either put your questions in the chat or the QA, and one of the hosts, Dr. Gonzalez, will ask Dr. Torres the questions at the end of the presentation. For CME, ASCP will directly email you the CME link at the end of the presentation. So with that, we are happy today to host Dr. Wanda Torres. Dr. Torres is an assistant professor of pathology at Harvard Medical School, as well as Cytopathology Fellowship Program Director and Director of Quality Assurance and Improvement in Cytopathology at Mass General Hospital. Dr. Torres completed her medical school at University of California, San Diego, followed by residency in AP and CP and fellowship in cytopathology at Beth Israel Medical Center. Dr. Torres is an active member of multiple societies such as College of American Pathologists, CAP, American Society of Cytopathology, ASC, and Association of Pathology Chair. She is the recipient of multiple awards, including prestigious 2022 recipient of the Top 40 Under 40 Award. She has a long list of publications and presentations in her subspecialty area, and today we are happy to have her with us, and she's going to talk about quality assurance and improvement and lab management in cytopathology. With that, I'm gonna give it to Dr. Wanda Torres. Wanda?
Thank you so much for that really warm introduction. I'm really excited to be giving this talk today. And I'm just going to start sharing right now. And it's a so quality assurance and improvement really is an area that I'm very passionate about. It really is integral, not just for the cytopathology laboratory, but in pathology in general, and really one of the cornerstones. So I'm very excited to be giving this talk, and I'm going to be focusing on applications to the cytopathology laboratory, but really these are key concepts that you can use in laboratory management. So a lot of these have broad applications. So by way of a very quick outline for this talk, so I'm going to begin with some background, including why do we need quality assurance and a quality improvement? What is quality management? What are different quality controls and performance measures that we can utilize? How can we capture this quality data? And how can we apply this quality data for systems improvement? So to begin with, why do we need quality assurance? Well, there's extensive regulation of healthcare at the federal, state, and local levels. And really, this is needed to establish best practices, to ensure compliance, and to provide safe healthcare for all. So what we really want is for testing to yield high quality, accurate results, and for there to be standardization across laboratories so that the results are translatable across laboratories. Now, the cytology laboratory is one of the most regulated of all the laboratories in clinical testing. And why is this? Well, if you think about it, cytopathology laboratories are prone to human error. And why is this? Well, if you think about how heavily manual the workflow really is in cytology, for instance, think about how many hand cytology specimens pass through from specimen collection to processing to when the slide actually hits your scope. And think about how many different types of specimens we actually receive in the cytopathology laboratory as well, and how processing and testing may vary depending on a lot of different factors. So there's just a lot of different junctures for mistakes to happen, even more so than surgical pathology. Moreover, we're being asked to do more with less and less tissue. So the doing more with less trend. So text complexity is also going up, and the samples that we're getting are becoming smaller and more valuable. So quality assurance really is integral to the practice of cytopathology. Now, we have to understand what happens if these standards aren't in place. And so we do have historical examples of what happens when we don't follow these or if we don't have standards. Now, this is an example that you may see in other quality assurance and improvement talks because it is so integral to our history. So in the 1980s, there was a lot of media attention to the issue of false negative PAPs. Now, at the time, there were these lax laboratory practices which allowed for this to happen. So basically, these what were referred to as PAP mills were offering bargain rates for services, and how they were doing that or able to do that is through incentives to rush specimen processing and interpretation. So, at the time, there really were no regulations for things like workload. Cytotechs were able to actually take cases home to look at, and they were being offered or paid basically piecemeal for this. So this led to a number of errors, and this culminated, or this environment culminated in this 1987 expose by an investigative journalist published in the Wall Street Journal. And at the time, this was the sort of language that was being used, where they were saying no longer would an American woman die of cervical cancer who has had a cervical vaginal cytologic examination and presumably has been victimized by unqualified and or incompetent cytotechnologists and pathologists. So when we don't have these mandates and standards in place, there is a chance that things will not go correctly. So, following that, we did have more strict guidelines in place. So the clinical laboratories that process patient samples currently are regulated by the Centers for Medicare and Medicaid Services, CMS. This is one of 11 divisions of the U.S. Department of Health and Human Services, which also includes things like the NIH, FDA, and CDC. So for services to be covered by Medicare, we need compliance with CLIA statutes. And CMS actually covers about 40% of Americans. So, it's a significant proportion of patients. So we started with the Clinical Laboratory Improvement Act, which was passed in 1967. This had some mandates, including rescreening of 10% of negative PAPs. But again, there was very little by way of other things such as workload limits. So really following the negative media attention that occurred in the 80s, this was followed quite quickly, relatively, by the Clinical Laboratory Improvement Amendments of 1988. And I'll go over some of those mandates on a following slide. There have been additional amendments since then, although the cytology specific mandates have not changed since then. And hospitals and laboratories need to be credentialed, and this can be done through a number of different ways. So we have proxies that conduct these surveys, including the Joint Commission, which uses a tracer type method, as well as the College of American Pathologists as well, which uses more of like a checklist through volunteer surveyors. So CLIA 88, what were some of the mandates that came out of this? So this included daily workload limits for cytotechnologists. So right now, there's a max 100 slides that could be previewed per a 24-hour period. And the minimum time for examining that is 8 hours. So this is not a performance target. Here it's just the maximum number, but so we do have now daily workload limits. There were also new quality control procedures that were put in place. This includes a 5-year retrospective rescreening, as well as the cytologic histologic correlation mandates, which I'll go over. It also mandated that pathologists review all abnormal PAPs, which includes reactive, reparative, and above, as well as all non-gynecologic cytology specimens, regardless of diagnosis. So even negative thyroids, needs to be signed off by a pathologist. There were some mandates for proficiency testing, also unannounced specialized surveys. These are to assess for competence. What came out of this was that we needed proper handling of specimens and as well as proper documentation. So things like policies need to be in place for documenting criteria for specimen rejection. Also, samples must be accompanied by a requisition form, and there's a number of things that are mandated to be on requisition forms as well. Now, this also includes test reports, have a number of things that must be included, including just general things like the name, address of the laboratory, the test that's being performed, pathologist signature, and also the results have to be descriptive. It can't be numerical, so you can't just say category 3. It has to say, atypical or whatever, but it can't just be a number there. Now, there were some other mandates as well, including how long report slides have to be retained for, the recs, how long they have to be retained for. There are some minimums. Now, this may vary state by state. Also, labs must compile annual statistics. Now, this is a big one. Now, there's a number of different statistics that we have to compile, including number of cases examined, specimen type, volume by diagnosis, number of unsat cases, etc. And I think the important thing about this is that although we must compile these statistics, really what we do with these statistics is more or less up to us. And what I want to convey to you through the course of this talk is that we really shouldn't look at quality assurance improvement as just basically something that we have to do to check off like a box, right? We really can use these to our advantage for systems improvement. And so I'll be going through some of these in the next slide. So what is quality management, just broadly speaking? Well, quality management is defined as the act of overseeing all activities and tasks that have to be accomplished to maintain a desired level of excellence. I really like this definition, which I've heard, where quality is getting the right result the first time and every time. So we want test results to be consistent, we want them to be accurate, and we want them to be precise. Now, quality assurance is the systematic monitoring of quality control results and quality practice parameters to assure that all systems are functioning in a manner appropriate to excellence in healthcare delivery. So this really includes an ongoing comprehensive program that analyzes every aspect of our operations. Quality control measures are those that are used for verifying a desired level of quality in individual tests or processes. So it's sort of a function of quality assurance in a way. Now, I like to think about quality management really as two broad sort of categories or tools that we have, two broad categories of tools. We have proactive measures and we have reactive measures. So proactive include those for monitoring and controlling quality prior to an adverse event or near miss. These include and-on signals, controlled charts. These can be used for targeted improvement. It also includes the thoughtful metric selection, tracking, and then feedback based off of these. We also have reactive tools as well. These are after an adverse event or near miss. So these include things like root cause analysis and cause mapping. So I'll discuss all of these through the course of this talk. One thing that I want to mention, somewhat briefly here is that I say here, adverse event or near miss. And I think a lot of times, especially with tax systems, we may feel compelled, or because we have to really address those that are actual adverse events, so causing some sort of harm. But equally important are those of near misses. And why is that? That's because a lot of times there's systematic issues underlying these, which are similar between these two processes. So, In one instance, it may be a near miss, but in another time, it may lead to patient harm. So I think paying attention to some of these, which may be, better, may be categorized as a near miss, can be just as important as those which actually cause patient harm. So something to keep in mind. So quality control standards. So first, we have the prospective 10% rescreen. So this was a QC requirement of all laboratories since the 1960s. So this predated CLIA 88, but it was reaffirmed by it. And it's the prospective rescreening of 10% of negative PAPs. So prospective means prior to sign out or finalization of the case. So this is where we could catch errors before it's finalized, and it's of negative PAPs. So again, anything reactive or above will automatically come to a pathologist for sign out. So this is rescreening of those that are negative. Now, the manner of selection in which this is done is largely specified by the laboratory. We have to do a combination of those which are randomly selected and then those which are from higher risk patients. So higher risk meaning perhaps a patient with history of SIL, squamous intraepithelial lesions. So really the manner of selection is specified by the laboratory, but it has to be some combination thereof. This must be done by a technical supervisor. So technical supervisor may be a cytopathologist, maybe a general supervisor, or it may be a cytotechnologist with three or more years experience over a 10-year period. Now, what is this good for? So it identifies cytotechs whose work is unreliable. And I don't want this word to have a negative connotation to people. We're all human, we all make errors. But one thing that we want to see with really anything in quality assurance is if we can identify trends. So if we see that somebody is consistently making errors, if they're consistently undercalling things that may be better as, ask or SIL, then that's something that we have to address. So now the drawback to this method is that it may actually take years to identify somebody with a high error rate. Studies have shown that the upgrade rate by doing this is less than 5% overall. So it's a very low proportion of cases are actually upgraded, even when you use categories of atypical to SIL rather than just negative to SIL. So it can take a long time to identify problems should there be there. But one thing that it may have some utility is an increased vigilance. Like if you know that 10% of your cases are going to be reviewed by somebody else, theoretically there is going to be some increased vigilance because of that. So there are some uses to this. Now, retrospective rescreen or the 5-year look back. This was introduced by CLIA 88. It's a rescreen of all previous negative PAPs during a 5-year period before a new PAP diagnosis of HSIL or cancer. So by doing this, the likelihood of detecting an error is theoretically greater than with a prospective rescreening of negative PAPs because you're starting with a lesion already and then rescreening negatives prior to that. So we have a higher likelihood of detecting an error by using this way. Now, studies have shown that the percentage of cases classified as unsat, ascus, or worse ranges quite widely depending on the study. And that may be due to a number of different reasons. So it could be inflated due to retrospective bias. So you may see different numbers depending on the study. But this is a quality control method that we have. Now, cytologic histologic correlation. So histologic outcome is considered the gold standard. And so cytologic histologic correlation is really the mainstay of QC in cytology. Needless to say, these correlations are not perfect. So why might there be discrepancies between cytology and histology cases? Well, you may be able to confirm both the cytology sample or interpretation as well, the histology interpretation is correct or appropriate. And in cases of that, it really comes down to sampling error. So anybody who does QA, or you can think even to your own practice, sampling error really comprises the vast majority of cytologic, histologic discrepancies. And that's due to a number of different reasons. In gynecologic cytology, we know based off of large studies that at least a third of high-grade lesions or worse are not identified by colposcopy. Also, you add on to that issues with embedding and sectioning, and you can see how this could play a big role in there being a discrepancy. However, cytologic or histologic interpretation errors do occur. These are less common. But as somebody who does our cytologic, histologic correlations, this really is an area that we can really learn a lot from. So one thing that I want to quickly mention here is, and I'll talk about this a little bit later too, is that we really want to use these for directed feedback. And really, one thing that's challenging to one person is likely going to be challenging to another person. So there's a lot of information that we can gather by doing these and looking where, quote unquote, errors occurred. And we can learn so much from this that we can, inform others about, and to help others learn from that as well. So I think that this is very helpful doing this. And again, we want to do it in a non-punitive way. Now, how this is done varies lab to lab. So a number of different things can vary, ranging anywhere from the definition of what a discrepancy is. So of course, a negative call versus a lesion is a discrepancy, but some people may consider a diagnosis of atypical squamous cells as a discrepancy if it should be a cyst. So, just the definition, the timing of review, the person assigned for the review, those can all vary. So, for in gynecologic cytology, is it the pathologist who's signing out the cervical biopsy, or is it who's doing the review at the time that they're signing it out? Or is the cytopathologist who signed out that the prior cytology case the one who's assigned to it? Or is it somebody who had no role in the initial case, right? So it's just somebody assigned for this. So really having so many choices is great, because it allows laboratories to select really what works best for them. So they can tailor this, not just this, but a lot of QA things to what works best for their practice. So I want to talk about some measures of performance. So being able to measure higher level performance parameters is desirable for a number of reasons. It's useful for ensuring that laboratory practice patterns are in line with published benchmarks. And a lot of time is devoted by accrediting organizations to developing standardized performance measures. So, we have things like proficiency testing, but those really measure competence. But these are really now what I'm talking about is being able to assess performance. So a day by day sort of performance. And I'm going to be talking initially, we talked about some quality controls. Those apply to laboratories in general, but can also apply to individuals, and same thing with these measures of performance. So they can apply to both individuals as well as the laboratory in general. Now this is nice. I take this from a paper that had been published a few years ago. This outlines quality metrics, which are divided by the phase of testing, as well as those that are required, and in addition to those that are optional. Now required, we talked about some of these quality metrics, including the prospective rescreening of 10% of negative PAPs. You have your cytologic, histologic correlations of both PAP tests, as well as non-gyn cytology cases, your retrospective rescreening. So there's a number of different things that we have to collect, but we also have some optional metrics that may be important as well. And I want to discuss some of these in the upcoming slides. Now, measures of individual performance. So we have a number of ways of assessing individual performance. We have subjective assessments. So this is, I thought, like a funny cartoon of what maybe a subjective assessment may be. However, we also want to have objective performance measures as well. So why is this? So if you think about it, if somebody comes to me and they have a subjective assessment, like either, oh, you're doing a fantastic job, that's great, but it's really not giving me tangible information about how I'm performing. Or if there's some negative feedback, it's always more, I think, digestible to be able to have numbers behind that as well. So for a number of reasons, it's good to have both, but you do want to have some objective performance measures as well. So this can include a number of different things: turnaround time, accuracy through histologic correlation, amendment reports. We actually just we just published our experience looking at amendment reports, because we do look at these closely here at MGH. But what I want to focus on are the diagnostic category ratios that measure a level of uncertainty, because I think there's a lot of attention to this now, that for a number of different reasons. And going into that for in a little bit more detail. So, why are we seeing more of this seen? Well, there's multiple cytology reporting systems now allowing for uniform reporting, with each category having an implied risk of malignancy. And so why this is because the diagnostic criteria that these reporting systems outline allow for standardization across practice settings and across individuals. So we can now do this because we have so many of it. It's becoming more standardized. So this results in allowing for cross-laboratory or cross-study comparisons. Now, the atypia category serves an important function because it bridges the gap between cases that are clearly normal from those that are clearly abnormal. So not everything is black and white, as you can imagine, right? So eliminating this category would result in a decrease in sensitivity, as well as an increase in the false positive and false negative rates. However, atypia is also a measure of uncertainty, right? So you can imagine why we may want to minimize use of this. So it may lead to clinicians misunderstanding a pathologist's report. It may contribute to decreased clinicians and patients' confidence in cytologic diagnoses. It may increase the clinician's diagnostic uncertainty, leading to excessive testing, to greater expenditure of resources, and also increase patient anxiety. And we really can't minimize that. And as well as decrease patient satisfaction. So this is a growing area of focus. Now, what I want to start off with is talking about how this applies to gynecologic cytology, because it's really more established in gynecologic cytology. So starting off with it, and we can apply a lot of these principles then to other non-gynecologic areas as well. So again, atypical squamous cells. So this is essentially a diagnosis of uncertainty. However, in gynecologic cytology, we have specific reference values, which are based on a number of things, including which prepper use. So we have the CAP checklist, we have interlaboratory comparisons that we can use. The general guidelines for using the atypical category is that it should be less than 5% of cases, and the majority of those, vast majority, should be atypical squamous cells of undetermined significance versus those that are more concerning for high-grade lesions. These are set by the Bethesda system. However, this can be affected by a number of things, including your patient population, right? Is it a low risk population? Is it a high risk population? So there's other measures that we can look at as well, besides just the atypical rate itself. So the atypical squamous cell to squamous intraepithelial lesion, or AST-CIL ratio, this is a proposed benchmark for quality control purposes because it's a quantitative physician-specific performance data. There's, at this time, no sort of real exact consensus on the ideal ask-SIL ratio. Now, there's been a number of large survey studies looking into this. The median ratio has been found to be about 2, and most laboratories range between 0.64 and 4.2. So generally, it's regarded that the ratio shouldn't be more than about 3 to 1, or at least that's the target. And the current recommendation by the Bethesda system is about 2 to 3 to 1. So ask-to-SIL. The reference values for ask-SIL ratio are specified by the CAP checklist. Generally, if the ratio falls outside the 5th or 95th percentiles, that's when we should start looking to reasons why. Now, I showed this study because it really was the first one to evaluate the use of this ratio in evaluating individual cytopathologist performance. So this study came out of Brigham and Women's Hospital in the early 2000s. They used the ask-SIL ratio for monitoring all cytopathologists, and they were able to provide feedback twice a year based off of these. And what they found was that there was a significant decrease in their pooled average with this method. So they were able to find this behavior modification based on feedback, but a very astute finding was that it could vary, right? So depending on the pathologist, it may not just be that getting feedback automatically meant that your ratio decreased. One person actually increased in this study. So, the importance is that feedback alone may not be helpful for everybody. So in those cases, you may need active measures as well. They did, the same group did have a follow-up study out of Brigham and Women's Hospital as well. At the time of the first study, they had also been converting from conventional smears to liquid-based preps. So, there was a potential confounder, but they found that this trend continued over time. And what they found was that monitoring this ratio helped identify outliers and enable them to take steps to rein in overuse of the ask interpretation. Now, one thing to consider, however, is that the ask-SIL is really a measure of the degree of uncertainty expressed as a ratio. So it's a fraction, meaning that it depends on 2 variables. So because of that, it's actually possible to obtain a normal ask-SIL ratio if both the ask and SIL categories are misused. So considering that, there's an added value to correlating this with the high-risk HPV positivity rates for ASCUS cases. And that's because this is an external standard. So it's being measured against an external standard that we have, because we have a benchmark for what the quote unquote expected rate for high risk HPV in ASCUS should be, which is about 50%. So about 50% of ASCUS cases should be high risk HPV positive. So this is more of an objective measure of risk of dysplasia in the ASCUS population. So this multi-layered approach now, using both the ask-SIL ratio as well as the ASCUS high-risk HPV rates, really makes this a more meaningful assessment of our usage. So Brigham and Women's Hospital, again, had a study looking into using both of these, and you can see that they were able to they were able to map both their ask-SIL ratio as well as their high-risk HPV for ASCUS rates. And when they're mapped together, you can see there's not really much, there's a slight weak correlation, a weak negative correlation between the two. But really, we're not necessarily looking for there to be a correlation between these two things, because they're 2 different measurements of performance. And I think that was the really astute and very elegant thing about what these authors were able to conclude, because they were able to use this for identifying and understanding perturbations from the norm that may be helpful to cytologists. So really what they're looking at these for is working schema that can address alterations from these based off of these two ratios. So by pictorial representation of what they were able to show, we have our indicators here. So we have the ASCUS-SIL ratio, and we have the percentage of high-risk HPV for ASCUS cases. So you can see based off of the SIL ratio, you can have it either be increased for a number of reasons. It could be normal or it could be decreased. But then by looking at the percentage of high-risk HPV for ASCUS, we can start to tell, well, what's the underlying reason that this is occurring? So for instance, if we take the first one where the ASCUS-SIL ratio is increased, however, in this case, the person's high-risk HPV for ASCUS is normal, this may be because the person is both overcalling reactive lesions as ASCUS, but also undercalling SIL lesions as ASCUS. So this will increase the ASCUS to SIL ratio, while at the same time, the percentage of high-risk HPV for ASCUS will be normal. And this is because you're getting contributions of cases that will be negative for high risk, which are now being called ASCUS, and ones that may be positive, which should have been, theoretically called SIL, as ASCUS as well. So it's making this diluted from both ends and making a normal number. So by going through, your combination of ASCUS to SIL and interpreting it in context of this other indicator, you can really start understanding what's going on, what's underlying these practice patterns. So in our practice, and I imagine in a lot of practices, this is similar. We actually give our cytopathologists every 6 months feedback into their ASC-SIL ratio as well as their high-risk positive ASCUS. We give both the benchmark of the CAP from the CAP checklist, for the ASC-SIL ratio. We also give from the ALT trial the target high-risk HPV testing goal. And we also put it in context of the lab average as well. And this is important because, again, your population may vary for a number of different reasons. So it is helpful to see it both by established benchmarks and in context to what's being called in your practice as well. So this can be very helpful for people to start understanding what is going on and trying to get you to go towards trying to address, if there is an issue, how you may go about addressing that. Now, one thing is that it's important to note that neither the ASC-SIL ratio nor the high-risk HPV positive rate for ASCUS is a measure of diagnostic accuracy. So we cannot measure true positive, false positive, true negative, false negative results based off of these, which are needed for calculating things like sensitivity and specificity. Accuracy really is measured by correlation with histopathologic follow-up or with blinded review of slides. So, despite this, they still have a valuable role in the laboratory and assessment of cytopathology performance, as they can identify practice patterns and allow for a more informed decision in adjusting diagnostic thresholds. There have been studies since those from Brigham and Women really showing the impact of these being able to use these metrics when some worrisome trends arise. So this was a study, a relatively recent study out of Cleveland Clinic, showing that they at one point had some by looking at their rates, they were seeing that there were some worrisome trends. And then because they were able to see this, they did have some educational interventions that they employed in both the level of the cytotechnologists as well as their cytopathologists. And by using these, and by having feedback on laboratory and individual metrics, they were able to start going back towards established benchmarks. And you can see how this persisted over time. So this can be a really helpful way to both detect if there's a worrisome trend occurring, and then how can we get back towards established norms. So, I just spent a lot of time talking about cervical cytology or gynecologic cytology, but a lot of these principles, especially now that we have more standard reporting systems, can be applied to other areas of cytology as well. So in thyroid cytology, so again, we have a 6-tier diagnostic system, the Bethesda system for reporting thyroid cytology. We do have a target upper utilization rate of about 10% established by the Bethesda system. There have been studies that have shown that the frequency of an atypical interpretation negatively correlates with histologically proven malignant outcomes. So if I'm calling more atypical cases, the likelihood that they're going to be a malignant outcome decreases. So that was shown by both this study by Vanderlaan and colleagues, as well as by other studies as well, which they showed in their study. However, we really don't use the atypia rate as a performance measure, at least on a scale equivalent to that as cervical cytology, and this could be for a number of different reasons. One is that correlation between resected lesion and cytologic interpretation is the gold standard, but most atypical thyroid nodules are not resected. So there may be an element of verification bias here. However, if we take the principles that we have learned from cervical cytology, perhaps we can start applying those in other areas as well. So there's 2 very nice recent studies using concepts similar to those in cervical cytology to thyroid cytology. So trying to use molecular testing results as a surrogate endpoint to get at the root cause of atypia overuse. And so you can see here from 2 different studies how they were able to use that, and they were able to use these to help explain practice patterns and provide directed feedback for improved calibration of diagnostic thresholds. So either just using the atypia rate to molecular findings, or using that atypical to malignancy ratio similar to an ask-SIL ratio as well with that molecular endpoint as well. Now, how about urinary cytology? So we have the Paris system, which established a 7-tier diagnostic system for evaluation and reporting urine cytology with the goal to make urine cytology reporting more standardized and comprehensive. Now, while there's no really set target utilization rates of atypia in here, we could perhaps start using this as well in certain scenarios. So this was a study that we had done out of Beth Israel Deaconess Medical Center a number of years ago when we had first implemented the Paris system criteria. And this study looked at the impact of the Paris system, but we also had a period of feedback as well. And we saw that there was quite a large impact with the new criteria on atypia rates with the Paris establishing the Paris criteria, or applying the Paris criteria. Now, with added feedback post that, there wasn't as much of a help, but that could have been because, and likely was, because we had such an impact already due to the applying the Paris criteria. So in another scenario, you can think how this might be helpful. So there actually was a more recent study that did show that targeted education could be used for reinforcing prayer system criteria and reducing urine cytology atypia rates. So there's this very nice study out of Vanderbilt with Margaret Compton. And really in their practice at the time, it seemed like they had applied the Paris system criteria, but didn't see as much impact on atypia as maybe some other places. So they had continued educational feedback, educational sessions, and they found that through use of these educational sessions, they were able to significantly reduce the rate of atypical diagnoses. So that really, I think, is the beauty of quality management in our laboratories, is you can really tailor it to your practice. So if you see that worrisome trends are starting to arise, you can use these principles in the ways that you see fit. So in one lab, there may not be issues with the urine atypia rate, so that may not be something that we want to trend, but in other practices, that may be something that we want to trend. So you can tailor a lot of these metrics to your own needs. Okay, so we talked about some of the metrics that we have, and I want to spend the remainder of this talk discussing how we can capture this data and then how we can use it. So capturing a quality performance data. So, again, we collect a lot of data. We examine a lot of different quality metrics. Why do we want to do this? Well, examination of data trends over time can be so helpful to understanding what's going on. So it can identify significant deviations or outliers. It can tell us if a target was met, and it could tell us if a process is stable and reliable. So some ways that we can visualize this. So we have both anon signals as well as control charts. So anon signals are from the Japanese term meaning light or lamp. And I really like this application or term because of the meaning too. So it was created by the Toyota production system in the 1940s. And it was a method that could really quickly signal that there was a problem within the production process by using this color coding system, right? So you have a green light, a red light, a yellow light, and a red light, right? So it was a way to rapidly identify if there was an issue at a workstation. And it really was to promote transparency within the teams and encourage them to come forward and identify issues rather than keeping them hidden in fear of judgment. And I think that is a wonderful application to QA in general and a wonderful theme to QA that we have to keep in mind. Now, control charts as well. So it's a specialized run chart where you have an average output that you can see, as well as you have established upper control limits and lower control limits, usually which are 3 standard deviations from the norm. And it's helpful in telling us if the process is stable and reliable. So looking at some of these, so we can use these for establishing dashboards, which can help us rapidly visualize these metrics and trends in these metrics. So I've included a mock example here of a dashboard that we use here at MGH. Where you can see it's based on the anon signaling type of red light, yellow light, green light. So you can rapidly see if there's issues occurring over time. So we have time, and then we have the metrics that we want to focus on here. So you may have, a few, or you may have a lot, depending on how many you want to keep an eye on. Again, we're collecting all of this data, but in terms of what we want to focus on, we may have, we can cater those based on individual laboratory needs. And again, this is a mock example, but you can see how rapidly you can identify that there's something going on here. So a worrisome or negative trend that you would want to address. Now, these have become very sophisticated over time. So this was out of a study again from Brigham and Women's Hospital, and they use this automated type dashboard using Tableau software. So this is still based on the anon type signaling where you have that green, yellow, red, but this is fully automated, and so it could give real-time, on-demand feedback to cytopathologists. I included this of their cytopathologist quality dashboard, but also to cytotechnologists and also as the laboratory in general as well. Now, a little bit more about control charts. So again, this points data over time, and you look at, this is for a specific metric. So the y-axis is the quality indicator. So this is, example of unsatisfactory rate, so percentage on the y-axis. And values that fall within the limits are considered expected, right? So we have the upper control limit and the lower control limit, and then we have values falling in between these, which are expected. We call these common cause variation. So when a process is stable and in control, you see only common cause variation. which results from normal operation of process. However, if something falls outside of these control limits, either the upper or lower control, these are what we've referred to as special cause variation. Now, these are much less likely due to random reasons. So these are areas that we can focus on as a quality indicator. So it may be that we want some sort of process improvement based off of this if we start seeing this. One thing I'll note too is that if you're seeing, even if they are common cause variation, if you're seeing a lot of them, straddling that upper point, for instance, that may also be something that you want to monitor as well, or it may be a cause for process improvement as well. I just quickly include here, we also use run charts here at MGH. So it's, again, the control chart is just a specialized version of this, but you can see how rapidly you can see if an issue has come up. So this is actually a real life issue when we went from how we reported high risk HPV testing platforms. We had quite a substantial uptick because we were using the wrong coded comments. So you could rapidly see what happened there and then use that as a root cause and a platform for root cause analysis. So how do we use quality data? Now, these can be triggers for analysis, follow-up, and improvement opportunities. So these could be if a target is consistently not met or if you see that the data is out of control. So these can be a trigger for root cause analyses, which can analyze incidents with harm or potential harm and be applied to all phases of lab testing. Now we have two specific techniques, which I'll discuss in more detail, cause mapping and also fishbones. And one thing that I want to stress here before going forward is that, we really have to get away from blaming individuals. And if you can think, our systems are so taxed, right? Again, we don't want to risk looking at things as just checking off a box, right? A issue occurred. It can be very easy to just blame an individual if a mistake happens, right? But through using what we call the substitution test, if you put yourself in that person's shoes, if you have a similar background, if you were under those same circumstances, if you can think of yourself of having made that same mistake, then likely there's systems issues at play. And I would say a lot of times when there is a problem, it is because of systems play and not because of an individual. And of course, I had to include the Swiss cheese model on at least one slide. And again, there has to be a number of things that align usually for an issue to occur. So quite quickly, so root cause analysis, talking about cause maps here. So this is a visual explanation of why an event occurred. So a story can be created starting with the harm event, then moving from left to right. And basically you're asking why at each step, and then you insert because. So, something happened, why, because, and then the reason why. Why did that happen? Well, because, and then so forth. So that evolves into detailed contributing factors. So this method creates connections between individual cause and effect relationships. You can actually have more than one adverse outcome that you're measuring here or looking into here. Now the fishbone diagrams, I would say that this is a bit easier if you're starting out because what you're doing here is you're putting all potential causes into general categories or buckets. And it's all possible related or unrelated root causes are listed. So we're not attempting to directly link relationships. We're just basically listing all possible contributing factors. Now this, reads from right to left, and it's usually just one outcome that we're addressing. And then you can think about all the basically buckets or categories when something arises. For instance, the people involved. So not just where the event occurred, but physicians, nurses, techs, could there have been contributing things, the equipment, test equipment, databases, things like that. So, looking at a number of different things. Now, I'd like to use this entertaining example. I'm sure it wasn't entertaining to those involved, but relative to what we do. I think that this is an entertaining example. If you think back a few years ago now, 2015, the Miss Universe pageant, Steve Harvey, the host, actually announced the wrong Miss Universe, right? And you could think, well, how could he do that, right? Well, he must have done it on purpose. How hard is it to announce the winner? However, if you really look into this, there's a lot of different things that can go into it. Suboptimal lighting, things are far away on stage. When you really look, and they did look into what happened in this case as well. He was a first-time host. He didn't know the winners beforehand. There was a last-minute change in how many names were announced. So when you really start looking into things, how many things really can affect that outcome, right? Or cause that outcome. Now, I won't go over this in detail, but I'll say, this is a nice sort of example of a real life laboratory example that we had. And I'll just summarize it in a nutshell in saying that there was basically a frame shift where the cell block slides were not matched to the thin prep slide. So the samples were not matched. So it was an incorrect, it basically was a frame shift error where the cell block was placed on the wrong slide for each case. Now, in a case like this, and we actually published this, so if you want to read more about it, you could go there to get more information about this case, because I think it highlights a lot of the principles at play here. So again, this is something that you can say, well, the histotechnologist, how could they put the wrong tissue? They should have double checked, right? But really, when you look into this, if we start thinking about this, and which is what we did in this case, there was a lot of different factors that went into that mistake happening. So it wasn't just a failure to verify patient identification. There are a lot of distractions going on that allowed for that to happen. There's a lot of issues with the LIS capabilities that allowed for that to happen. With the materials, at the time, they were using just a single ice tray for cutting and separating cases. As a result of this, they actually made a number of different changes, including separating things in that ice tray to help prevent that from occurring again. So rather than just saying, blaming an individual, if you start looking into the underlying issues that may be there, you can really learn a lot about the processes underlying. And a lot of times it is systematic or multiple system issues because we have such complex processes. This again, so you can also, I show it in the fishbone diagram, but we also did it for the cause mapping as well. Just to briefly, before ending, talking about types of errors. So, we focus a lot, especially in training, the importance of diagnostic errors. We don't want to misinterpret a test, but really the vast majority of errors are due to pre-analytic errors, and a lot of those are due to labeling errors. So, we want to look at different phases. And in terms of undertaking quality improvement projects, there's a number of different things that we want to consider, and we have to consider these in order to have really effective projects in place. So, the initial steps include securing support and resources, as well as forming multidisciplinary teams. So this, I think, is extremely important. So multidisciplinary teams, including, cytotechnologists, your clinicians, histotechnologists, trainees. This can be so important because, a lot of people are actually very invested in this. So you can see, how much they are invested in this. So they'll be able to really shine a light on what's occurring on their levels as well, because they're the ones who are going to know best, what's going on in the laboratory, what's processing that we may not be able to get even just by, talking. So we need to all discuss these things. You want to be able to outline the project or plan a timeline with these involved members as well. Now, you want to have teams that include people from the impacted groups, again, as I mentioned, And you want to be able to define SMART project aims, so that you want to have a specific, measurable, attainable, relevant, and timely aim. Ideas should be tested over time, so this may take some trial and learning. So don't be discouraged at first. You want to keep going, more trials, more learning. And you need to also understand that there may be barriers to change. This may include things like lack of funds, difficult system issues, current workflows, or organizational culture as well. So with that, in summary, quality assurance and improvement forms an integral cornerstone of our practice that is needed to ensure safety for all. Performance measures help identify areas of weakness and opportunity for improvement. We need to consider risk in all phases of care in order to better serve our patients. And pathologists have an opportunity to play a key role as healthcare advocates, given our unique understanding of the life cycle of a patient sample. So with that, I thank you. I think we're going to open it up to questions. If we don't get to all of your questions, or if you're listening to this at another time, when it's uploaded, please feel free to contact me. Also, one quick plug as well. If I went through a lot of these topics very quickly, I wanted to touch on broad topics. We actually will be having an ASC, American Society of Cytopathology, cytology laboratory management workshop, which is coming from a lot of specialists in our field and those in laboratory management. So be on a lookout for that in the upcoming months as well. So with that, thank you. And if there's any questions, I'm happy to field any of those. And I'm going to stop sharing, I think.
Thank you, Dr. Toros, for that excellent comprehensive talk. We are a little bit over time, but I think we can fit in a couple questions. If you have a question, please use the Q&A or the chat function in Zoom. And we do already have two quick questions from Stephen Lau. He asks, when pathologists have to screen non-GYN slides in lieu of cytotechnologists because of their absence, does the 12.5 slides per hour limit still apply? And if the slides are totally acellular, as in some thyroid cases, does the limit still apply?
Yeah, so there are changes to those limits depending on if you have a cytotechnologist or not. So you have to look up those measurements as well. So there are requirements in place for that, so it alters a little bit.
All right, thank you. Anyone else? Any questions? You can use the Q&A or the chat feature. All right, well, it was definitely a comprehensive talk. It sounds like you answered everything they were wanting to know.
Perfect. Again, it'll
actually
be uploaded so they can digest it, look at it again. So again, if there's any questions at any point, please feel free to contact me as well.
We just got a couple more, of course, as soon as I said that. Allie Brown asks, any advice on how to break through to surgical pathology with enhanced QA monitoring?
Yeah, so there's a number of different considerations in that, right? So I think when I came on here, at least, it's not just, I would say, surgical pathologists, but maybe just groups in general. I think one thing that helps in general is to show how important it is, right? So we started instituting things like QA conferences here, so cytologic, histologic correlation conferences, where you can show that data to people. And it was really impressive how quickly people really got on board with stuff. So I think, some people may be hesitant at first because, you're talking about at times diagnostic errors. But if you can show, like I said, and I alluded to this, one thing that's challenging for one person is oftentimes going to be challenging to somebody else. So I think showing people the importance of this and doing it in a non-judgmental, non-punitive fashion is really important. And I think that goes a long way.
Great, thank you. And we also have a question from Lisa Dwyer-Joyce, who asks, what kinds of high-risk cases do you include in your 10% rescreen in your lab?
So we generally will include ones that have had history of lesions. So like I very quickly alluded to this. So patients who have had CILs in the past. So that's what we use as defining criteria of high risk in our practice.
All right, thank you. I think we are actually all set this time. So once again, thank you so much for that excellent talk. We really enjoyed having you here at Virtual Pathology Grand Rounds.
Thank you so much again for having me as well.
Thank you.